Good morning. Right. So, just 1 minute, guys. I'm just having a look at it because I don't think the streaming is live. Just 1 minute, guys. I'm just having a look at it because I don't Okay, I think I'm live. Can I listen from you guys? Are you there? So, how many of you guys are there? Okay, so I'm live, guys. I'm live. Okay, so I think there was a bit issue, but I'm live now. So, right. So, how many of you guys are still there? So, I can see only one of you is there. Okay, right. So let us begin today's session. I'm really sorry for the inconvenience and the delay from my side. So can I hear it from you guys who is there? Hello guys. Whoever is watching this, can you just tell me hello? Can you give me a thumbs up? Right? Okay, so today we'll be talking about the image-based questions in general surgery. So can you tell me? So let us start. Let us start and begin with our first question. So intrauterine USG of a patient has been shown in this, and what is the finding? So has been showed in this finding, and what is the diagnosis? So what has been shown in this particular image is the intrauterine USG. So can you tell me what is the diagnosis of this particular patient? Right. So Indra, good to have you. Hi. Right. I'm really sorry for all the inconvenience. Can you tell me what's the diagnosis over here? So what is the diagnosis in this particular patient? So I think you just covered this in the session which we just talked about for the urology. Well, what is being seen in this particular image is why anteurethral valve? Indra, why anteurethral valve? No, it's fine. It's a urethral valve, no doubt about it. But why an anteurethral valve? It is a posterior urethral valve, right? See, anteurethral valve doesn't present like this. So this is a characteristic keyhole appearance. What do you see in here? So you see a characteristic keyhole appearance. It is not a anteurethral valve. The answer is D, posterior urethral valve. So please understand. What is the diagnosis over here? It is a posterior urethral valve. Okay, so please understand this. Okay, so posterior urethral valve is something which is an intrauterine, like a congenital anomaly which presents in the intrauterine. And if you do an intrauterine USG in these patients, what you see? You see a characteristic keyhole appearance. Now, what is the posterior urethral valve? So what is the valve? Valve is something which allows the flow of substances only in one direction. Now what is happening in this particular patient? There is a valve which starts at the verumontanum and it goes to the urogenital diaphragm, or let's say the external urinary sphincter. So the urine is not allowed to come out, but if you try to pass a catheter, it will go in. So this is a characteristic keyhole sign which you see in the intrauterine USG in a patient with a posterior urethral valve. And if I ask you what is the investigation of choice for this posterior urethral valve, so what is the answer, guys? So what is the investigation of choice for the posterior urethral valve? The answer becomes MCUG, micturating cystourethrogram. Okay, so I hope you all know this. What is the investigation of choice for this? It is MCUG, that is micturating cystourethrogram. What you see in MCUG? You see a dilated bladder with a dilated posterior urethra. So what you see in this? You see a dilated bladder with a dilated posterior urethra, and that is basically the investigation of choice for posterior urethral valve. So this is our first image, that is the posterior urethral valve, that is fine. Now let us move on to the next image. Now this is a very, very interesting clinical scenario. Now a patient was brought to the casualty when he experienced an instant loss of erection while having a sexual intercourse and heard a snapping sound. What is the diagnosis? So can you tell me guys, what is the diagnosis? I can see 5-6 of you are there online. So can you please tell me what is the diagnosis of this particular patient? Anybody guys? Right. So Indra, what is the answer to this particular patient? Now this is an important clinical scenario which can be asked to you. I think a question was based on this particular topic on your JIPMA. Okay. So what is here? Here you have a patient who is brought to the casualty. So it is an emergency condition. So penile fracture, very good. So sonic, that is completely fine. The answer is penile fracture. So this is a characteristic clinical scenario. See, understand, penile fracture usually occurs when there is a trauma to the penis in the erect state. So if at all during sexual intercourse, the patient hears a snapping sound and it is followed by the rapid kind of loss of erection, this is characteristic clinical scenario of a patient suffering from a penile fracture. So yes, no doubt, the answer here is a penile fracture. Now another thing is, what you see in here, in penile fracture you see something which is called as a eggplant deformity. Okay, eggplant deformity or eggplant shape of a penis. Now what is this eggplant deformity or eggplant shape of the penis? So please understand, like eggplant, what is eggplant? Eggplant is basically the brinjal. So it is also referred to as a brinjal shaped penis or eggplant deformity. Eggplant is basically the English name of brinjal, that is fine. Right. So please understand, eggplant deformity or a brinjal shaped penis, that is a feature of a penile fracture. And this characteristic clinical scenario points towards the diagnosis of a penile fracture. Right. Now, let us move on to the next particular question. A patient has been detected as an incidental liver lesion. On performing an MRI, we got the following image. What is the diagnosis of the patient? Is it a hepatocellular carcinoma? It is a hemangioma? It is a hepatic adenoma or a focal nodular hyperplasia? What is the diagnosis to this particular patient? Can you tell me guys? So it is an incidental finding and you have performed an MRI and you're seeing this image over here. So what is the diagnosis guys? So Sonic, Indra, Vedashri, what is the answer? And anybody else who is there online? A very simple image, a very, very important image. So Indra is trying to say B, hemangioma. Is she correct? Anybody else can guide her? What is the answer to this particular question? Well, right. Okay, Vidashri, you are saying C. Why C? Why hepatic adenoma? Why do you think it's a hepatic adenoma? So please understand, it is answer is in fact B. So why hemangioma? Very good, Indra and Sonic. The answer is in fact hemangioma. Now why is this hemangioma? Because you are seeing a characteristic sign. What is the characteristic sign which you're seeing here? You're seeing a characteristic light bulb sign. What you're saying? You're seeing a light bulb appearance or a light bulb sign. So rest of the liver is dark, but this particular lesion is white. So this is a characteristic light bulb sign which you see in patients with hemangioma. And again, what is the most common incidentally detected liver lesion? It is again a hemangioma. So everything points toward this incidentally detected liver lesion, and on the MRI you see a very, very bright image. So this is a characteristic thing of a light bulb appearance which you get in the MRI. Okay, so please understand this. What do you get in the CT scan? If you perform a CT scan in hemangioma, what do you get? You get a centripetal enhancement. Okay, so please understand, in the CT scan what you get? You get a centripetal enhancement. Okay, this is again important. So what you get in CT scan, you get a centripetal enhancement in patients with hemangioma. Now, moving on to the next question. A patient who is a chronic alcoholic comes to you with a severe pain in the epigastric region. The CT scan of the patient has been shown to you. What is the diagnosis? A very, very simple question again. Okay, so what is the patient? Patient is a chronic alcoholic coming to you with a severe pain in the epigastric region, and this is a CT scan which has been shown to you. What is the diagnosis, guys? So Indra, Vidashri, Sonak, any other? So Kamal, yes, what is the diagnosis? It is a pancreatic adenocarcinoma. Okay. Indra is saying B, that is chronic pancreatitis. Okay. Anybody else? Chronic pancreatitis. Okay. Very okay. Anybody else? So Kamal and Indra has answered. Don't you guys want to answer? Please answer, guys. So Vidashri is again saying it is a B, chronic pancreatitis. Well, guys, absolutely correct. Please understand. Now, Kamal, I really don't understand why you answered it as a pancreatic adenocarcinoma. So what I'm trying to tell you here is, what is a chronic pancreatitis? It is a condition where the pancreatic kind of parenchyma has been kind of gone away, and there is a lot of calcified stones inside the pancreas, and it is basically pancreatic calcification which has occurred. So can you appreciate this? This is a CT scan. This is your pancreas, and what you're seeing in here, you're seeing a calcifications inside the pancreatic parenchyma. So no doubt the answer here is in fact a chronic pancreatitis. So patient, chronic alcohol, severe epigastric pain, CT scan showing a calcifications in the pancreas. No doubt the answer is chronic pancreatitis. Okay guys, so good. So Preeti, yes, you're absolutely correct. The answer is chronic pancreatitis. Now Indra is saying that string of pearl appearance. So yes, you do get a string of pearl appearance, but where do you get this? Mostly it is associated with ERCP. If you perform a ERCP in a patient with a kind of a chronic pancreatitis, then you end up getting a string of pearl appearance. Okay, so yes, that's fine. Now this is interesting. Can you tell me the diagnosis of this? A patient with a head injury has brought to the hospital. CT scan of the patient has been done. What of the you get the following image? What is the diagnosis of this particular patient? So can you tell me what is the diagnosis? I want each one of you to answer, guys, because this is an interesting question. I want you to answer. So is it, what is it? It is an acute SDH, it is a chronic SDH, it is EDH, it is SAH. What is the answer? Not that right. Yeah, Kamal, it was a chronic pancreatitis for the previous thing. What about this? Okay, so Indra is saying it is an acute SDH, right? Videshi is saying it's a B, that is okay. Now Indra is again saying acute SDH, that's fine. What is the answer, guys? I want each one of you to answer. Like, I know the couple of you are answering, but I want others also to answer. Please participate. That is the best way to assess yourself. So what is the answer to this particular question? And it's a short break. It's like a 5-10 minutes relaxing session for you. That's it. Right, chronic SDH. So Indra changed to the chronic SDH. Is it so? Well, yes, guys, it is a chronic SDH. Please understand something. What is a characteristic thing about, yeah, black in chronic? Very good. So what is the characteristic thing? Okay, so if I ask you what is the investigation of choice for the head injury, it is non-contrast CT scan. Now, why do you perform a non-contrast CT? Because the acute blood appears white. Now, if you look at this particular image, what you are seeing that there is a lens-shaped opacity, not the lens-shaped, sorry, crescent-shaped opacity. There is a crescent-shaped opacity, but the upper part of this crescent-shaped opacity is basically darker, okay, and the lower part has somewhat hyper-intense thing, okay. So if you get this mixed kind of a thing, then what do you get? If you get this mixed kind of a thing, it is pointing towards the chronic SDH. So please understand, chronic SDH. The diagnosis over here is a chronic SDH. Now, if I ask you what is the investigation of choice for this? So investigation of choice specifically for the chronic SDH, it is not the non-contrast CT scan, it is an MRI. But if you do a non-contrast CT scan, this kind of image you will see. So please understand, this particular image, it is pointing towards the chronic SDH. It is not a acute SDH, okay? The shape and everything will be exactly the same. The only difference will be there will be heterogeneous lesion, okay? So above portion will be black, lower portion will be a bit hyper intense. So that is a mixed bag. That is basically a chronic SDH. Now, this is a harmonic scalpel which has been shown to you. Now, what I'm trying to ask you is, the tip of the harmonic scalpel, it vibrates at what frequency? So again, a very, very simple question, but an important question. So what is the mechanism of action of a harmonic scalpel? It is based on the USG. So it is basically high frequency high, not the exactly frequency USG. It is basically the high frequency vibration of the tip, which brings about the vessel sealing and all those things. Okay. So can you tell me what is the answer to this particular question? Can anybody answer? So Vidashi, Preeti, Indra, Sonak, Kamal, please answer, guys. What is the answer to this particular question? So what is the frequency of vibration of a harmonic scalpel? Is it 550 Hertz, 5500 Hertz, 55,000 or 5,50,000 Hertz? Please comment a bit fast so that I can move on and I can discuss the particular question. Nobody wants to answer? Please answer. Okay. So right. So Sonic has come with the answer. He's saying C. Geetanjali is also saying C. Well, yes, guys. Your guys are correct. It is basically 55,000 Hertz. So please understand, this is an important MCQ. What is the frequency of vibration of the harmonic scalpel? It is 55,000 Hertz. Okay, so Indra, please remember, it's fine. Even if you have no idea, that's completely fine. But please remember, the frequency of vibration of the harmonic scalpel is 55,000 Hertz. Okay, so please keep in mind, it's a kind of a numerical which they may ask you. Now, identify the investigation which has been shown in this particular image. So can you tell me what is this investigation which has been shown in this image? Is it a flexible colonoscopy? It is a capsule endoscopy? It is a virtual colonoscopy or a reconstructed MRI? So Indra, Gitanjali, Saumak, Vidashri, Preeti, Kamal, anybody guys? What is the answer to this particular question? Can you tell me what's the answer? Again, a simple question, not that a difficult question, guys. Anybody? Okay, so Indra is saying it is C. Okay, she's not sure. Is it okay? So Indra, okay, I'm really sorry. But, right, so Kevin is saying it's B. Kevin Shah is saying it is capsule endoscopy. Well, Varun is again saying C. It's virtual colonoscopy. Well, guys, you're absolutely correct. Kamal and Indra, you're absolutely correct. The answer is in fact virtual colonoscopy. So please understand, this is a virtual colonoscopy. This is I personally feel that this is an important image. It might come in your exam. Okay, so please. So at least once it will come in your exam. So this is basically a virtual colonoscopy. So how it is done? It is basically a reconstructed, it is a 3D reconstructed CT scan. Okay, so what is it? It is a 3D reconstructed CT scan, and it is not a reconstructed MRI. It is a 3D reconstructed CT scan. So flexible colonoscopy is different. Capsule endoscopy, it is like a small endoscope, like a small capsule which you eat, and then while it passes through the intestine, it gives you the image. That is fine. That is again different. Virtual colonoscopy, it is a 3D reconstructed CT scan. What is the drawback of a virtual colonoscopy? You cannot take up a biopsy. You do get to look at the intraluminal and the extraluminal things, but you cannot take up a biopsy in the virtual colonoscopy. But if you're performing a kind of a flexible colonoscopy, definitely you can perform a biopsy. Okay, so this is a basic difference between virtual colonoscopy and the actual colonoscopy. Now this is a very, very simple image, no doubt about it. So I think all of you must be getting it right. So the patient suffering from which kind of burns? Okay, so this is a patient who is suffering from burns. What I'm trying to ask you is what kind of burns is being suffered like in this particular patient? What is the kind of burns? Can you tell me guys? Anybody? I understand you must be thinking what a simple question, but yeah, please write down. I'll feel good. So come on, what do you think? It is superficial second degree burns. Well, yes guys. Okay, so Ahmad is again saying superficial. Very good, guys. So answer here is in fact a superficial second degree burns. Everybody knows it. Very good, guys. Now please understand a basic difference between superficial second degree and the deep second degree. What is the difference? The difference is in the superficial second degree you get the blisters. In the deep second degree you don't get the blisters. How will you characteristically tell what is a deep second degree burns? In this, the pain sensations will be reduced, but the pin prick sensation will be maintained. So this is a characteristic thing which they tell you about the deep second degree burns. No blisters, pain sensation reduced, but pin prick sensations maintained. Okay, right. What about the third degree burns? What is the characteristic thing about the third degree burns? You get no pain. Okay, so what? No, please understand. Scar, it is a thing of a third degree burn. Please understand this. Scar you don't get in the second degree burn. Scar you get in the third degree burn. Okay, so please understand this. And in the third degree burn, you don't get any pain. No pain in the third degree burn. What about the first degree burn? You don't get any other lesion. All you get is a blanchable erythema. Okay, so blanchable erythema. That is the only thing which you get in the first degree burn. So first degree burn, blanchable erythema, second degree burns, these blisters, third degree burns, what do you get? You get kind of reduced pain sensation, but pin prick sensation is maintained, and in the third degree burn you get a characteristic scar formation. Okay, so these are the buzzwords which they will give you if at all they are trying to test you on the classification of the burns. Okay, right. Now this is again a very simple question. Can you tell me guys, a patient is presenting to you with a drooling of saliva from the mouth on day 1 of life. X-ray has been shown. What is the diagnosis? Now this is a very simple question again, but yeah, can you please take it for me? So, right, what is the answer? No doubt. It is N. Kamal is saying it is N1. That is esophageal atresia. So, well, guys, I know you guys are thinking what's a silly question, but yes, definitely the answer is in fact a esophageal atresia. So, what you are seeing over here is you are seeing a coiled rice tube in the neck. Okay, so what is this? Because this is because of the esophagus is atretic. See, understand guys, I can put up a very difficult MCQs also, but what I'm trying to do in here, I'm trying to put up a simple MCQs so that you have the knack of it. I can put up a difficult MCQs, but that won't help you for the NEET 2020. Okay, so that's why I'm trying to revise the basic stuff with you. That's it. That's the reason I'm putting up a simple MCQs in this particular session. Right. So this is no doubt it is an esophageal atresia. Thank you so much for all of you guys for answering. I felt really good. Thank you so much. Right. So esophageal atresia, no doubt. So characteristic buzzword is drooling of saliva, day one of life, esophageal atresia. What is the most common type? The most common type is type C. So what is happening over here? There is atretic of the upper esophagus with the lower esophagus communication with the trachea. So this is basically the most common type of a tracheoesophageal fistula. Okay. So right. This is about this particular thing. What else? So if they ask you what is the investigation of choice for H-shaped tracheoesophageal fistula. For H-shaped tracheoesophageal fistula, what is the investigation of choice? Can you tell me? The investigation of choice for the H-shaped tracheoesophageal fistula. Anybody can tell me? It's a repeat question from Jipmer and Ames. Okay. For the H-shaped tracheoesophageal fistula, what is the investigation of choice? The answer is tracheobronchoscopy. Okay. What is the answer? It is a tracheobronchoscopy. Please understand this. This is a one-liner, may be asked. It is already a repeat question from Jipmer and Ames. So please understand. Investigation of choice for the H-shaped tracheoesophageal fistula is tracheobronchoscopy. Now, moving on to the last question, I decided I'll put it a bit difficult. Okay, so a flap which has been shown in this particular image. So first and foremost, what is this flap? Okay, so very good. So someone can answer bronchoscopy. Yeah, already covered. So it is a tracheobronchoscopy. That's fine. Now, can you tell me what is the flap which has been shown in this particular image? What is the type of a flap which has been shown? What will you label it as? So can you tell me, guys, what is the type of the flap? Can anybody tell me? Please write down. It is an important question again. It can be asked. So Sonak, Chandan, whatever. So thoracodorsal artery. That's fine. But can you tell me what's the flap? What is the name of the flap? Okay. Good, guys. Good. So Vidashi, well, right. So only Vidashi fell into my trap. All the other people did not fall on my trap. Okay, so please understand. Very good, guys. I'm really impressed. This is busy. Hi, Anik. Good to have you. Okay, how are you doing? All the best, man. Okay, so this is an LD flap. What is LD flap? LD flap is basically latissimus dorsi flap. What is an LD flap? This is used for the breast reconstruction. Okay, so LD flap. So what is this based on? It is based on thoracodorsal artery. Okay, so thoracodorsal artery or thoracodorsal vessel or the thoracodorsal pedicle is the one which is feeder vessel for the latissimus dorsi flap, and that is used for the reconstruction of the breast. That is important. Good that you know. Right. Now another thing is the tram flap. Okay, so can you tell me tram flap? Tram flap is based on which artery? Can you tell me? So it can be based on superior epigastric artery or an inferior epigastric artery. That's fine. But what is the disadvantage of tram flap? Just understand one thing. What is the disadvantage of tram flap? It leads to the weakness of the abdominal wall. Okay, so weakness of abdominal wall. Okay, so if you use a tram flap, that is transversus rectus abdominis muscle. So yes, it can be based on inferior or superior epigastric artery both. If it is based on inferior epigastric artery, it is a type of a free flap. If it is based on the superior epigastric artery, it is a rotation flap. Okay, so yeah, that's fine. And abdominal hernia, why? Because patients land up into weakness of the abdominal wall and patient may land up into hernia, right? So that's all for today. Thank you so much for joining me today. I'll stay here for a couple of minutes if you have any doubt, if you want to ask me something. So it was a very short session organized by me so that you can have a knack of it in a couple of minutes or something, right? So just a small break. If you're not following me on Unacademy, please follow me. I'll feel really happy. And yeah, if at all somebody wants to join it, you can use my promo code. At present, we are offering it for 1499 bucks for 1 month. It's fine. Your exams are very near. I don't think it will be helpful for you. Maybe for your junior batches, it might help. That's fine. If you have any doubt related to surgery, not related to surgery, regarding studies, anything, you can definitely type it. I can definitely try to put my views over it. Okay. Well, thank you so much for that. And right. Thank you so much and happy studying. If you are done with it, you can go. If anybody wants to ask me something, you can stay. It's all fine. Okay. So you can just have a look at which is your college. Okay. Well, my college is GMC Surat. I completed my MS General Surgery from GMC Surat. I have been teaching since last couple of years, and yeah, recently I've joined the Unacademy. Right? Okay. Well, like anything else you want to ask? And yeah, I have a session today. Yesterday the screaming had stopped. Today I have a session at 1:30 in which I'll be basically talking to you about your progress and about your anxiety and whatever you are facing problems in the particular exam, because after giving the mock test, some of you are shattered. I completely get that. So I'll be talking to you regarding that in 1:30 at 1:30 p.m. I do have a live session. That will be a very, very short live session of 15 minutes, 10 to 15 minutes. I tried to cover it yesterday, but it stopped. The streaming stopped due to the internet error. So I'll be conducting that session today. So if you want to join, you can join me on at 1:30. So if you have any doubts, you can definitely put up. Make quiz on instruments, definitely. Indra, I will definitely plan a quiz on instruments. Okay, so let's schedule it for 25th of December, Christmas gift. Okay, so 25th of December at 25th of December, let's say at 12 o'clock. Okay, so 25th of December, 12 o'clock, I'll make a quiz. Okay, so scheduled. Okay, 25th of December, 12 o'clock, there is a quiz on instruments. Okay, so thank you so much. Right, so I think you guys don't have any doubts, so I'll just call it a day for today. And yeah, if you, right, most welcome. Right, so if you want to connect with me and talk to me about, it will be a very short session. I'll be just trying to telling you that everything is fine, don't panic and everything. So if you want to just connect with me, you can connect with me at 1:30 p.m. after half an hour, and I'll be talking to you about your anxiety and all those things. Okay, that's completely fine. It will be a very short session, 10-15 minutes. If you want to take a break, do come and join me over there. Okay, so I think I'll call it a day. Thank you so much for joining me, let's say 10-15 days before the exam, and all the best, guys. See you soon. Bye.